where are we now in the adjuvant or neoadjuvant treatment of gastric cancer? Again, recently conducted randomized trials have defined new standards of care. So in the West, after the publication of the MAGIC trial in the 2000s, perioperative chemotherapy without radiation, pre and post-operative chemotherapy without radiation was the standard. This showed improvement in survival compared to surgery alone. Many of us were never convinced that ECF or variants were the optimal regimen. Did epirubicin really add a benefit? So German investigators conducted the FLOT4 trial, which was a head-to-head comparison of the FLOT regimen, 5-FU oxaliplatin and docetaxel, versus ECF or a variant. The FLOT regimen was superior on all outcomes. Most importantly, it translated into about a 9% improvement in 5-year survival compared to ECF. Also, patients had a higher rate of pathologic response. Also, there was a higher rate of curative resection. The curative resection rates were improved by about 7%, and about a 7 to 8% higher rate of node-negative patients. So improved surgical outcome, better downstaging, and a modest 9% improvement in 5-year survival. So the FLOT regimen is the new standard for perioperative chemotherapy in the West. In Asia, trials have looked mostly at adjuvant chemotherapy, post-operative chemotherapy, and the standard of care now in Asia is combination chemotherapy after D2 gastrectomy. In Japan, the standard would be a year of S1 plus 6 months of docetaxel. I think a more applicable standard, which could even be applied to Western patients, would be results from the recent ARTIST-2 trial from Korea. This was a post-operative trial in which all patients underwent D2 gastrectomy, and then patients were assigned to one of 2 different chemotherapy regimens. A year of S1, which was the standard in Japan for many years, or a truncated 6 months treatment with S1 oxaliplatin. And it turned out that S1 and this was only in patients that had node-positive disease. They focused on node-positive disease. And in node-positive disease, 6 months of S1 oxaliplatin was superior to a year of S1. So that kind of comes in line with adjuvant regimens in the West, where we use a fluorinated pyrimidine plus oxaliplatin. So S1 oxaliplatin is the new standard adjuvant. Previous Korean studies had also suggested that 6 months of capecitabine oxaliplatin is an appropriate adjuvant treatment. And the other issue that the ARTIST-2 trial addressed was it randomized patients also to get or to not get radiation, and radiation added no survival benefit. So collectively, these studies show that either perioperative or adjuvant chemotherapy in the setting of good, appropriate surgery with D2 gastrectomy, perioperative or adjuvant chemotherapy is a standard of care. Radiation does not add a benefit. So chemotherapy alone would be the standard. If we're going to give it perioperatively, we have evidence that the FLOT regimen is superior, so 5-FU oxaliplatin and docetaxel. In the post-operative adjuvant setting, 2-drug therapy would be appropriate, either a fluorinated pyrimidine oxaliplatin or fluorinated pyrimidine plus docetaxel based on the Japanese data. So where does that leave us in terms of incorporating some of the newer targeted agents or immunotherapy drugs in the adjuvant setting? Well, we do know that immunotherapy drugs have a modest signal of activity, that even in the PD-L1 positive patients, it's really a small minority of patients that benefit from these drugs. So because of that, are these drugs really going to have an impact in the adjuvant setting? Because we know that 50% of patients are PD-L1 negative. Are these drugs really going to have a meaningful impact? So we are awaiting the results of a trial of pembrolizumab added to perioperative chemotherapy. That is the Merck study, in which all patients get perioperative chemotherapy, pre and post-operative chemotherapy, and patients are randomized to get or not get the inclusion of pembrolizumab. This trial did not select for PD-L1 positive patients or MSI high patients. One of the criticisms of this trial is that the regimen that was chosen for perioperative chemotherapy was a fluorinated pyrimidine and platinum. They did not include the taxane, because in the West now we believe that we really should use a taxane as a triplet preoperatively. So one of the criticisms of that trial is perhaps the perioperative chemotherapy was not optimal. But we await the results of this trial, and we'll have to see whether there is an impact of combining immunotherapy with perioperative chemotherapy. There also are adjuvant trials ongoing in Asia, looking at immunotherapy as part of a postoperative adjuvant strategy. And then there are some other pilot studies in the West combining checkpoint inhibitors with perioperative chemotherapy, looking at a signal for activity. One interesting area that's emerged is MSI as a biomarker in the adjuvant setting. We do know that 5 to 7% of gastric cancers are MSI high, and there's very provocative data from Asia and Europe that MSI high patients have a better outcome, even with surgery alone. MSI high patients have a better survival outcome with surgery alone. And a recent pooled retrospective analysis combining Asian and Western studies suggested that in MSI high patients, they may achieve the same survival with surgery alone than if they get chemotherapy. That chemotherapy did not improve outcome. And there was actually a trend towards inferior survival in MSI high patients getting adjuvant chemotherapy compared to MSI high patients getting surgery alone. So MSI may emerge as an important biomarker to look for in patients that we're considering for pre or postoperative chemotherapy in gastric cancer. It may be that these patients are best served with surgery alone, that perioperative or adjuvant chemotherapy may not add a benefit to those patients. Then, of course, that begs the question, would those patients be candidates for immunotherapy as an adjuvant treatment, because MSI high patients are the ones that we see the dramatic responses in metastatic gastric cancer. The problem is it's a rare subset of patients. It would be hard to design an adjuvant trial that only addressed 5 to 7% of the population. And already these patients have better survival with surgery alone, 80, 85% 5-year survival. So it's going to be difficult to design a trial to improve upon that survival with or without the use of immunotherapy drugs.